Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our new series entitled, What's the Point? And we're in section 1, and today we're going to start with part 3 of section 1. And in this section, we're focusing on important principles and important procedures involved with your physical examination. In later sections, we're going to talk about important principles and procedures involved with the interview process with your examinee. And in another section, we're going to talk about important principles and important procedures involved with producing your finished and final product, which is your QME report. And in this series, we're emphasizing points that seem to be commonsensible, but that may not be intuitive at first glance or first blush. And in part 1 of this section, we talked about the point involved with reflex testing in your physical examination. In part 2 of this section, we talked about sensory testing, and we talked about important points involved with sensory testing. And in today's discussion, I want to talk to you about important principles and important procedures involved with your physical examination, and specifically your physical examination involved with the permanent impairment evaluation. And I want to spend some time contrasting the procedures that we use in performing our physical examination for the assessment of permanent impairments. And I want to contrast that with the physical examination procedures that we use in our clinical practice, which have as their purpose the determination of a diagnosis. And the point of today's discussion is going to be, and I'll emphasize this as a recurring theme throughout today's discussion, the point is that the physical examination procedures that we use in our clinical practice have nothing to do and are completely different than the physical examination procedures that we use in our QME practice. And the reason is, in our clinical practice, we do a physical examination for the purpose of determining the diagnosis. Once we establish the diagnosis then drives the treatment protocol. Well, in our qualified medical evaluation practice, by the time we see examinees, the diagnosis has long been established. And these examinees have gone through exhaustive treatment and are usually at the end of their treatment cycle. So what's the purpose of examining the applicant, the injured worker, using procedures that have as their motive to determine the diagnosis? It's like comparing apples and oranges. In the permanent impairment evaluation, the principle that I want you to remember is that in our physical examination, we're examining for the presence or absence of impairments. Our physical examination procedures are specifically adapted to assess for the presence of or the absence of permanent impairments. So the principle is know the impairments, and examine specifically for them. And this is completely different from the procedures that we use in our clinical practice, because in our clinical practice, we don't examine new patients to determine the presence or absence of permanent impairments. We do a physical examination on them to determine what's the diagnosis, what's the condition that this person is presenting to us with. And once we can determine what's the diagnosis, we can then fashion a treatment program and a treatment protocol designed to address the diagnosis and to address a return to pre-injury or pre-condition status. Whereas in our qualified medical evaluation practice, this has already long been established and has already long been addressed, sometimes for as much as a year, as much as 2 years. I recently saw an examinee last week who had been receiving treatment for 2.5 years. So he was at the end of his treatment cycle. The purpose of my evaluation was to determine, okay, at the end of all of this time, at the end of all of this treatment, does the examinee have any permanent impairments that qualify for a rating under our workers' compensation system here in the state of California? So the principle is to know the impairments and examine for the presence of or the absence of those impairments. And I'll share with you some of the permanent impairments that we're going to be looking for in relation to the spine, in relation to the upper extremity, and we'll use the shoulder as an example for the upper extremity, and then also for the lower extremity under Chapter 17. So I have some important materials to share with you today. I have my AMA guides with me here, and I'm going to ask you to go ahead and get your AMA guides out, because you're going to want to lay your own eyes on some of these specific references that we refer to throughout today's discussion. So I'll give you a minute to go ahead and get your own AMA guides, and I look forward to being back with you here in just a couple of moments as we begin part 3 of section 1 of our new series. And today we're specifically focusing on the permanent impairments, to know the impairments and examine specifically for them. So I look forward to being back with you here in just a couple moments. Okay, I'm back with you now, and I have several materials that I want to share with you today. And to begin our discussion today, I just want to share with you a little bit of philosophy that was shared to me very recently at a seminar that I attended about 2 weeks ago. And let me just tell you a little bit about that seminar. During the course of this seminar, one of the presentations involved a panel discussion. And by panel, I mean that there was a defense attorney on the panel, there was an applicant attorney on the panel, and there was a workers' compensation judge on the panel. And the discussion involved how to improve our QME reports. So we had 2 attorneys and a judge addressing an audience of doctors to tell doctors how doctors could improve their reports and make the work of these parties, the attorneys and judges, easier. So it was a very informative and very enlightening discussion. And each of the parties, meaning the defense attorney, the applicant attorney, and the judge, provided a list of suggestions and recommendations that we could implement to improve the quality of our reports. And I found the discussion and the listing of recommendations from the defense attorney to be very interesting. And one of the things that he said, and I want to share that with you today just to establish our philosophy for today's discussion, he was talking about things to not do. These are don'ts. You know, we have do's and don'ts. These are don'ts. These are don'ts from the defense attorney. He said, don't check one's lifetime of reason and common sense at the examination room door and immerse oneself in the parallel universe of workers' compensation in the state of California. And let me just repeat that for you, because it has some profound instructions here for us as we go about our work as qualified medical evaluators. He says, don't check your lifetime of reason and your common sense at the examination room door and immerse yourself in the parallel universe of workers' compensation in the state of California. And isn't that an interesting instruction? What he's telling us is to take a look at our case and to approach our case commonsensibly, reasonably, to use our lifetime of accumulated medical knowledge and medical reasoning skills to arrive at opinions and conclusions that are accurate, that are appropriate, and that are a true representation of the examinee's condition on the date of our evaluation. And so many times I see that doctors, and I'm guilty of this myself at times also, doctors lose their common sense and start immersing themselves in this other world that we refer to as workers' compensation. Which, let me ask you, why should the world of workers' compensation be so different from the world of our clinical practice? How can we approach our patients in our clinical practice with a reasonable expectation that, number one, they respond to treatment, number two, that they recover from otherwise uncomplicated conditions, and number three, that they go on to resume their normal pre-injury level of function and their pre-injury level of activities of daily living? How come we have one set of standards for patients in our clinical practice and a completely different set of standards for examinees in the workers' compensation system? And this defense attorney is saying, please, 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 would you approach these examinees with some degree of reason and some degree of common sense? Now, along those same lines, I notice that in the evaluation, the physical examination of injured workers, we also employ a double set of standards. And the physical examination that we employ in our clinical practice is much different from the physical examination that we employ in our permanent impairment evaluation. Now, this is an example where this is appropriate, because in this instance, the universe of workers' compensation and the assessment of permanent impairments is different from the universe of assessing patients in our clinical practice for a diagnosis. And I want to expand and elaborate on that in today's discussion. So the recurring theme that we're going to iterate over and over again in today's discussion is to know the impairments and examine for them. Know the impairments. Going into your evaluation, you need to know what are the possible impairments that your examinee could be presenting with. And then, once you know what those impairments are or could be, you specifically examine the injured worker for the presence or absence of those impairments. That's the procedure involved with the permanent impairment evaluation. And let me just illustrate this principle a little bit. If we turn to chapter 15, the spine chapter, and we turn to page 382, the AMA guides tell us that under the DRE method of evaluating for permanent impairment, there are certain specific clinical findings that qualify for a permanent impairment rating under the DRE method, and those are listed on page 382. Now, as we go through this list, I want you to think about the physical examination that you do for the assessment of these impairments and compare that to the physical examination that you do in your clinical practice for the determination of diagnosis. Okay? So let's just go down this list. It says that permanent muscle spasm and or muscle guarding qualifies as a permanent impairment. Asymmetry of spinal motion is a permanent impairment. It's a loss of use or loss of function or derangement of the spine. Asymmetry of spinal motion. Non-verifiable radicular root pain is a permanent impairment. Reflex alterations is a permanent impairment. Weakness and loss of sensation is a permanent impairment. Atrophy, if it's permanent, is a permanent impairment. Radiculopathy is a permanent impairment. If we have electrodiagnostic verification of radiculopathy, that qualifies as a permanent impairment. Alteration of motion segment integrity is a permanent impairment. Cauda equina syndrome, if it's permanent, is a permanent impairment. And loss of bladder function qualifies as a permanent impairment of the spine. Now let me ask you, in our clinical practice, I want to just illustrate this principle by asking you to imagine a new patient who comes to your office today complaining of lower back pain. you're going to take that patient through a series of examination procedures, and you're going to do various procedures such as Kemp's test, and you may do a procedure called Milgram's test, and you may do a procedure called Gainsland's test, and you may do a procedure known as Lewin's test. Well, the reason we do Kemp's test is to determine if the patient is suffering from an injury to the facet joints, or may be experiencing what we refer to as facet-mediated pain. Okay, this is something we do in our clinical practice. Well, it's interesting. On page 382 and 383 of the AMA guides, nowhere is it listed that facet injury is a permanent impairment. So in our permanent impairment evaluation, why would we even do Kemp's test? Why would we do Lewin's test? Why would we do Gainsland's test for assessment of the sacroiliac joint? Nowhere here in the AMA guides is sacroiliac sprain, strain, sacroiliac subluxation, sacroiliac dysfunction. Nowhere here is that listed as a permanent impairment. So you can completely drop those procedures from your permanent impairment evaluation, because those procedures do not reveal conditions that qualify as permanent impairments. Okay? So now that we know what the permanent impairments are, let me ask you, if muscle spasm and muscle guarding, if they're permanent, meaning if they're present at the time that the examinee is determined to be permanent and stationary, those qualify as a loss of use, or derangement of the function of the spine. These are the AMA guide's definitions for impairment: loss of use, or derangement of function. If muscle guarding is present at the permanent and stationary date, that qualifies as a permanent impairment. So let me ask you, what is your physical examination procedure to determine the presence of muscle guarding? Let me ask you, how do you determine the presence of muscle guarding? What are your physical examination procedures that tell you that indeed this examinee is presenting with muscle guarding? What's your procedure? Interesting, isn't it? This is a subtle mental shift and a subtle nuance that distinguishes our permanent impairment evaluation procedures as separate and distinct from those that we use in our clinical practice. So what is your physical exam for muscle guarding? You need to have an assessment protocol to determine the presence or absence of muscle guarding. You do not need a procedure to determine the presence or absence of facet syndrome. You don't need a procedure to determine the presence or absence of sacroiliac syndrome, because those conditions are not listed in the AMA guides as permanent impairments. Interesting. Okay? Let's develop this idea a little bit more. Let me ask you, let's say you have an examinee coming up for an evaluation with you, and you know that the examinee suffered an injury to the shoulder. Let me ask you, what are the permanent impairments of the shoulder? What clinical findings, if they're present, qualify for a permanent impairment rating for loss of use, or derangement of function of the shoulder? Well, while you sort of ponder that, let me ask you another question. Think about your physical examination procedures in your clinical practice that you would do to assess a new patient who presents to you with complaints of shoulder pain. You're probably going to do some procedures such as range of motion of the shoulder. You're going to check the range of motion of the shoulder. You might do Apley's scratch test to assess for range of motion of the shoulder. You might do various physical examination procedures to assess for shoulder impingement syndrome. You might do various examination procedures to assess for sprain of the acromioclavicular joint or the acromioclavicular ligaments. You might do various physical examination procedures to assess for subluxation of the bicep tendon. And these are all various assessments that we do in our clinical practice to determine what is the diagnosis, what is going wrong with the shoulder. And once we can determine what's the diagnosis with the shoulder, we can then provide a treatment program to address those conditions. Well, nowhere in the AMA guides is sprain of the acromioclavicular ligaments listed as a permanent impairment of the shoulder. Nowhere in the AMA guides is impingement syndrome of the shoulder listed as a permanent impairment. Nowhere in the AMA guides is instability of the biceps tendon in the intertubercular groove listed as a permanent impairment of the shoulder. So why on earth would we even go through these physical examination procedures? There's no need to, it's superfluous, and it's really wasting time and going through unnecessary motions that won't in any way and can't in any way contribute to your final opinion for or against permanent impairment of the shoulder. So let me ask you, what are the impairments of the shoulder? What does the AMA guides list as evidence of loss of function, loss of use, or derangement of function of the shoulder? Well, impairments of the shoulder include the following. Number one, arthroplasty of the shoulder. Specifically, the AMA guides refer to resection arthroplasty of the distal clavicle. Now, you may opine that other arthroplasty procedures, other surgical interventions of the shoulder may qualify as a permanent impairment of the shoulder by analogy to resection arthroplasty, but the AMA guides specifically refer to resection arthroplasty. Number two, so if the examinee has had resection arthroplasty of the shoulder, the AMA guides tell us that that qualifies as a permanent impairment, okay? Number two impairment of the shoulder is range of motion or loss of range of motion of the shoulder. So that tells us that we need to assess the range of motion very thoroughly to determine the presence or absence of loss of range of motion. Number three impairment of the shoulder is decreased strength. Decreased strength. So this tells us that we need to perform manual muscle testing of the shoulder in at least 6 different directions to assess for the presence of or the absence of strength changes around the shoulder. Number 4 impairment of the shoulder is shoulder instability. Shoulder instability. So this tells us that the AMA guides require that we do a thorough assessment of the stability of the glenohumeral joint. And if we find that the glenohumeral joint actually has instability, that qualifies as a loss of use, or derangement of function of the shoulder. Nowhere do the AMA guides talk about impingement syndromes, sprain-strain syndromes of the shoulder. Nowhere do the AMA guides talk about slap lesions of the glenoid labrum. Nowhere do the AMA guides talk about tear of the rotator cuff, unless and until these specific conditions cause loss of strength, loss of range of motion, and or instability. Not until then, and only then, do those conditions qualify for permanent impairment. So we don't provide for a permanent impairment rating due to the condition, due to rotator cuff tear, due to slap lesion of the glenoid labrum. We don't provide permanent impairment for the condition. We provide a permanent impairment rating for the effect that the condition has on the residual function of the examinee. And if those conditions don't cause loss of range of motion, if they don't cause a loss of strength, if they don't cause instability of the shoulder, if they have not resulted in a resection arthroplasty procedure, it does not qualify for a permanent impairment rating. Isn't that incredible? Now the guides tell us that we can combine some of these impairments, and some of these impairments we cannot combine. So for example, we cannot combine permanent impairment due to loss of strength with a permanent impairment due to shoulder instability, because those provide overlapping permanent impairments. On the other hand, we can combine permanent impairments due to decreased range of motion and shoulder instability. We can combine impairments due to arthroplasty, decreased range of motion, and decreased strength. And we can combine permanent impairment due to decreased range of motion, decreased strength, and shoulder instability. So of all those permanent impairments, the loss of range of motion or decreased range of motion can be universally combined with all of the other impairments. So what does this tell us about our physical examination for the shoulder? Our physical examination for the shoulder involves a meticulous evaluation of range of motion, a meticulous evaluation for loss of strength, a meticulous evaluation for shoulder instability. And I find that many doctors have absolutely no physical examination protocol for the assessment of shoulder instability. So I'm asking you that as relates to the AMA guides and the assessment of permanent impairments, you need to ramp up and improve your physical examination for the assessment of the impairments that are described in the AMA guides. And with regards to the shoulder, that specifically involves a fabulous examination for the presence or absence of shoulder instability. Are you getting it? The principle is know the impairments and examine specifically for them. So procedurally, what does this mean? Procedurally, this means that as you approach the date of your evaluation with your upcoming evaluation with an examinee, you need to know what physical examination procedures you're going to be doing. You need to know what sequence you're going to be doing those in. You need to have your examination form already printed out for exactly for the assessment of those permanent impairments, and you need to be prepared in advance to examine for all the possible impairments. Let me say that again, for all the possible impairments that are listed in the AMA guides. Now this gets especially interesting when we get involved with the lower extremity. And I want to just briefly go through some of the impairments for the lower extremity to further illustrate our recurring theme today, which is to know the impairments and examine for them. Okay, so in chapter 17 of the AMA guides, the lower extremity chapter, the guides tell us that we have three different types of impairments. We have anatomic impairments, we have functional impairments, and we have diagnosis-based impairments. So here's what you need to do. You need to go through the AMA guides and construct a physical examination protocol for the assessment of all of the anatomic impairments. You need to construct a physical examination for the assessment of all of the functional impairments. You need to construct a physical examination procedure for the assessment of all of the diagnosis-based impairments. And let's just go through these very briefly, one at a time. And as we do, I want to ask you to think about your physical examination procedures and how you would assess for the presence or absence of these impairments. Okay, let's talk about the anatomic impairments. The first one of which is a limb length discrepancy. Do you assess for limb length discrepancy? It is one of the impairments. You need to, in every single lower extremity case, do a limb length discrepancy assessment. If the limb lengths are equal and there is no discrepancy between limb lengths, then the examinee does not qualify for a permanent impairment due to limb length discrepancy. So what does this require? This requires a tape measure, and this requires visualization, and this requires a chart and a table in your exam form wherein you can record these findings. You need to have a specific section in your physical exam template for the assessment of limb length discrepancy. Muscle atrophy is one of the anatomic impairments. So this involves the obtaining of measurements. Ankylosis of the hip, of the knee, of the ankle, of any of the foot articulations qualifies as a permanent impairment for the lower extremity. Are you doing an ankylosis assessment on every single articulation of the lower extremity in every single case? You must. You must. You must include this in your physical examination. If the examinee does not have ankylosis of any of the lower extremity articulations, then of course they would not qualify for a permanent impairment rating. But if they do, then they would qualify for a permanent impairment rating. This is something that we would typically not assess for in our clinical practice, but in our qualified medical evaluation practice, it's required that we assess for ankylosis. Okay, another anatomic impairment is arthritis of the joints. Arthritis of the femoroacetabular joint, of the knee joint, of the ankle, foot joints, any of the lower extremity joints must be assessed in those cases where you have a lower extremity injury. Now, arthritis of joints is assessed on X-ray studies, okay? Now, many doctors do not obtain lower extremity X-rays in every single lower extremity case, but the AMA guys require it. It's required that we assess for the presence of post-traumatic arthritis or its absence. It's either present or it's not. If you've had an examinee who's had a lower extremity injury and time has passed and lo and behold they have no post-traumatic arthritis of that joint, then they don't qualify for permanent impairment. But if they do have it, they qualify for permanent impairment, a permanent impairment rating. How are you going to determine this? You have to order the X-ray studies on each and every case to assess for the presence of or the absence of post-traumatic arthritis. It's one of the assessments. Now, this is not something that you would typically do in your clinical practice, and this is just another example of how our clinical exam and our permanent impairment exam are apples and oranges and are horses of a different color. Okay, another one of the anatomic impairments along the same lines of arthritis of joints would be chondromalacia. But typically talking about chondromalacia patella. So you need to have a fabulous examination for the assessment of the presence of or the absence of chondromalacia of the patella. Peripheral nerve injuries qualify as permanent impairment rating, so you need to have a fabulous physical examination of all the sensory peripheral nerves and all of the motor peripheral nerves. And the sensory nerves, well, the motor nerves would include your examination of the obturator nerve, your examination of the femoral nerve, your examination of the sciatic nerve, including both the common peroneal division and also the tibial division. And then for the sensory nerves, do you realize how involved the sensory evaluation for lower extremity peripheral nerves is? You need to examine and assess for function of the lateral femoral cutaneous nerve, the genitofemoral nerve, the femoral nerve, the posterior femoral cutaneous nerve, the obturator nerve, the saphenous nerve, the lateral sural cutaneous nerve, the superficial peroneal nerve, the deep peroneal nerve, the sural nerve, and then all of the sensory nerves in the foot, such as the medial calcaneal nerve, the medial plantar nerve, the sural nerve, the saphenous nerve, and the lateral plantar nerve. Now, this is not something that you might do in your clinical practice, but in our permanent impairment evaluation, it's required. Finally, the anatomic assessment includes a vascular exam and an assessment for the presence or absence of causalgia or complex regional pain syndrome. So you need to have an assessment procedure for CRPS, for CRIPS, for the presence or absence of causalgia. You need to go through that assessment on each and every lower extremity case, because the AMA guides describe that as one of the permanent impairments. And doctors, I think you get the point. We could go on and talk about the physical examination for the functional impairment, and we could go on and talk about the physical examination for the diagnosis-based impairments, but I think you get the point. And let me just conclude with one more point. With regards to functional impairments, one of the functional impairments of the lower extremity is a derangement of the gait. Derangement of the gait. Now, let me ask you, how do you assess for derangement of the gait? How do you assess that? Do you have a formal procedure in place to assess for the presence of or the absence of derangement of the gait? And what I'm encouraging you to do, and what I'm telling you that you must do, is that you must have a formal gait evaluation procedure with each and every examinee. This is where you take the examinee outside of the examining room and you observe them through gait, through substantial distance, to allow you to have an adequate assessment of their true and natural gait pattern. And you need to assess this from the front, from the rear, and from the side, and you need to go through an exact formal protocol where you assess for the presence or absence of derangement of gait. It's one of the permanent impairments that we're obligated and required to assess for. So I encourage you to adopt a formal gait analysis procedure into your routine protocol, and also to adopt other procedures that are required for the assessment of the anatomic, of the functional, and the diagnosis-based impairments. So after all of this discussion, let's summarize by reviewing what's the point? What's the point here? And now that we've talked about it, some of these principles may seem to be common sense, but at the outset and at first glance, they're not intuitive. It's not intuitive to us that taking x-rays on each lower extremity case would be required, but it is. It's not intuitive that a formal gait analysis on each and every lower extremity case is required, but it is. And the point and the take-home message is that the physical examination procedures that we do in our permanent impairment evaluation are completely different from the physical examination procedures that we would use in our clinical practice, because each of those have their own separate, unique, and distinct assessments. In our clinical practice, we're assessing for a diagnosis. In our permanent impairment evaluation, we're assessing for the presence or absence of the impairments. So I encourage you to study the AMA guides and adapt your physical examination procedures accordingly. Now, for those of you who have not done this or who have not considered this, we can simplify the entire procedure for you. And I want you to know that we have templates for the physical examination already prepared. They've been evolving and developing over the last 10 or 11 years. And our physical examination templates are in their perfect final form. They exactly comply with all the requirements of the AMA guides, and it's not necessary for you to go ahead and reinvent the wheel and readapt newly in your mind first and then on paper a physical examination procedure that covers every single procedure that's required. We've already done this for you. So if you need those templates, we have those available on our website. Just go to the online store, click the QME templates, and then scroll through the listing of templates that might be of use to you and purchase those that you're most in need of. But I encourage you to use those templates because it's not necessary for you to reinvent the wheel. It's already been done through thousands and thousands of physical examinations of injured workers. So doctors, I hope this helped you. The take-home message is that you can now feel comfortable and confident in changing your physical examination for the assessment of the presence or absence of permanent impairments, and discarding those procedures that might have some value for you in your clinical practice but have no value for you in your permanent impairment evaluation. You want to adapt your physical examination procedures to those procedures that are exactly described in the AMA guides, and that is the point for us as qualified medical evaluators. So doctors, I hope this helps you. Hope this helps you fashion and streamline your physical examination procedures to those procedures that are really relevant for the type of work that we do. So I want to thank you for taking the time to join me on this week's video. Look forward to being with you on next week's video as well, where we continue with our new series, What's the Point? Continuing with important principles of the physical examination. So for now, this is Dr. Perry Carpenter. I'm wishing you best of success in your career as a qualified medical evaluator.